Nath Lenka, working present as assistant professor in cardiology in High-Tech Medical College and Hospital, Bhubaneswar. Today, I am going to tell some few things about the what latest updates in hypertension has come, so that we can keep to our colleagues, our physicians, and our cardiologist friends, and also students up to date about the this hypertension. As you know, hypertension is a non-communicable disease, and if you go by statistics, the total deaths out of which majority is affected by CVD, that is 45% of people in the age group of 40 to 70 years, that is the 69 or 70 years, is the majority where people working age group. 45% death attributed to this CVD, and if you take total whole disease, of which 63% is due to the non-communicable disease. Out of that, one is hypertension. The others are like diabetes and other chronic diseases. So hypertension is a major concern and is a risk factor for cardiovascular disease. And if it is actually, hypertension is very poorly treated and also poorly controlled, not only by the patients but also by our physician friends and by physicians also, because there is very little symptom acutely. So it goes on notice. Patient do not take medicine regularly. Even they stop medicine frequently. They'll tell we don't have any symptom. How will take medicine? But they don't know what long term effect what is going to happen. And if you go by the WHO, around 38% of men and 32% of women more than 28 or 30 years, they have hypertension. And half of people, that's around 51% men and 41% of female, half of them are with hypertension are unaware of the condition. That is, it is a tip of the iceberg we are seeing. What we are treating is a tip of the actual iceberg, because most of patients are not detected. In the long term, there will be very problem in cardiovascular mortality. There patients will have present with severe, patients will present with heart failure, patients will present with any cardiovascular disease. So medication was used to control blood pressure in fewer than 1 or in 5, and that is only 20% was treating worldwide, and 1 to 4 in female patients. This is the latest study published in the Lancet in 2021. And International Society of Hypertension has released that 2002 Global Hypertension Practice Guidelines, that the inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource poor settings like in our country, and optimal care efforts to evidence-based standard care, and whereas essential standards refer to minimum standards of care to allow specification of standards of care for low resource settings. The SEC, they have taken stage 1 and stage 2 hypertension like that, depending on the blood pressure. With stage 1, the management starts with non-pharmacologic therapy. That is, first we start the non-pharmacological reduction of weight, reduction of salt intake. If the blood pressure remains uncontrolled despite this your physical activity, weight reduction and salt restriction, many things, and diet control, despite that, if the patient comes to after 6 to 6 months, if he has hypertension remaining, then he needs definitely pharmacology treatment with drugs. And in the setting of COVID, we all know that ARDS is a complication of fatal condition in COVID infection, and long inflammation that can improve respiratory functions if we control with this hypertension also. In 8,500 patients of age 60 to 80 in China, the intensive target trimmed 26% of the composite CVDs. So definitely, if we are controlling the blood pressure very good, the result is also very good. With regard to your hypertension therapy that require lifelong medical therapy, as you know, BP control should be there so the lifelong. It is not for 1 day or 2 day treatment. So it should be emphasized to the patients, and fixed dose combinations are usually preferred. Usually, first choice is ACE inhibitor or ARB along with one CCB or diuretic. This is the first line of treatment until it is contraindicated. Any drug is contraindicated. And since early July 2018, products containing valsartan has been recalled worldwide. The reason for the detection of known carcinogen, that is nitrosomylia, that is NAMDA, which is found in candacetin, ivacetin, losartan, olmesartan, and valsartan. So WHO has carcinogen found one carcinogen element in this product, so it has been recalled. Valsartan has a recall has accompanied significant increase in rates of emergency department visits to 6%. So in Hygia study, what they compared that during the night time they included more than 19,000 patients and primary, and they followed up for more than 6 years actually follow up. So it is a very large study and long follow up study. So in this study they found and also measured the ambulatory BP, and they found that the relative risk reduction when we give one drug in the morning and to some patients, and another group we gave the antihypertensive therapy drug at the night time, and that showed that the nighttime therapy actually improved the relative risk reduction. And if you are giving one patient suppose 2 antihypertensive therapy, ideally it should be given one in the morning and one in the night, so that it covers the 24 hours. So BP reduction should be whole 24, not only during sleep or during the hours. So it will be whole 24 hours. 24 hours it should be reduction of the blood pressure. That improves the outcome. So thank you for listening and for your kind patience also. Thank you.